first of all, thank you everyone so much for joining us this evening. It's really lovely to see you all. Just a bit of housekeeping beforehand. So obviously, if you can keep yourselves on mute throughout, that's absolutely brilliant, as it just reduces disruptions. There will be an opportunity to ask questions at the end, but if you think of any throughout, because obviously I know it's when you've got it there in your brain, sometimes it's easier just to ask it, please feel free to pop it in the chat, which I'll type in a second, and we'll come back to it at the end. So first of all, just a bit of background. So obviously, stem cell transplants are something which isn't necessarily a common treatment within the WM world, but it is a treatment that does happen occasionally. And I think it's something which is very interesting and people have got a lot of questions around. And like I've mentioned throughout my role, and like we mentioned in our webinar last night, for WMUK, we feel that it's really important to collaborate with other charities that may have expertise in other areas that can give you better information about these services than what we could. At the end of the day, we specialise in WM, other charities specialise in other areas of your care. And I think it's great if we can get them to come and give you that more in-depth knowledge. So to do that, I'm going to hand over to the lovely Rachel, who's very kindly joined us from Anthony Nolan this evening. So Rachel, if you'd like to take over.
Thank you very much, Alison. Hello, everyone. Really nice to be here, have the opportunity to speak to you all. I have got a lovely slideshow to share with you, so I'm just going to pull that up. And hopefully see that okay. I can't see many people now, but there should be a slideshow up on the computer now. So I'm Rachel Miller. I am lead nurse at Anthony Nolan, which is a stem cell transplant charity. We're quite an unusual charity in as much as WM and many of the other charities that are in the blood cancer, blood disorder space are disorder or disease charities, whereas Anthony Nolan is actually a treatment charity. The treatment of stem cell transplant is used in many different blood disorders and cancers, and actually in some non-malignant disorders as well, multiple sclerosis, sickle cell disease, etc. So we cover a broad range of different disorders, and it's actually quite a niche, small treatment area. So we have that in common, because I'm very aware that WM is a small and niche disorder in the world of blood disorders and etc. So I've been working in stem cell transplant for nearly 20 years, all of that time in the NHS until I moved into my role at Anthony Nolan 2 years ago. So I'm going to talk to you a little bit tonight around what a stem cell transplant is, when and why it might be utilised, and then a little bit about Anthony Nolan's support services, so that you've got some further understanding of the support that might be out there for you if it was a treatment option that you were considering. So many of you may be aware of or remember the story of Anthony Nolan. He would have been 50 last year. It's the charity, Anthony Nolan charity, is 50 next year, but he was 2 when his mum realised that a transplant might be a treatment option for him, and that's when she started her campaigning. But there's a lovely video here that just explains that far better than I can, so I'm going to pop that on, and hopefully you should have sound, etc. when I play it.
Anthony Nolan was a person that needed a stem cell donation, and his mother went on a sort of campaign to find a match.
And she was inspired to set up the register that we know as Anthony Nolan today. As a mother going through something so horrific, I can really relate to Shirley Nolan. On the 28th of May 2020, we got told the devastating news that Evie had this really rare blood disease called plastic anemia.
When I was 14 years old, I was diagnosed with acute myeloid leukemia. I think from there, nothing really felt real anymore.
I've always known Evie as a strong little girl. Oh God. She's just got this beautiful soul. First time we heard of Anthony Nolan was when her consultant said that they would need to search stem cell register to see if there was a donor match for Evie.
I was told that without the transplant, I wasn't going to make it much further than the Christmas of that year.
I think it's really important that anyone who requires a transplant can get one, and that's not the case today. We're working incredibly hard to try and improve the outcomes so that patients have that option.
While I was sat there waiting for Anthony Nolan to find me a match, it was a terrifying and nerve-wracking time, and all you think about is the what ifs, and what if we don't find a match? What if we don't find somebody who's going to be able to save my life?
In the last few years, we've seen new treatments, new ways of matching patients and donors at a rate that we've never seen before. The day of transplant really is the first day of the next journey for a patient.
I knew that they could be anywhere in the world, the person I donated to. In some way, I'm connected to someone that I don't know and may never meet, but I know that I've gave them another chance to live, really.
I've never met my donor. I don't know what they look like, but I love them with all my heart, and I know that to me, they are part of my family.
We're actually working on research that helps to improve and guarantee patients' quality of life after transplant. That all started with one little boy.
I think Shirley's a superhero, really. She's gone from trying to save her son to then saving people all across the world.
Unfortunately, he wasn't able to make it, but look at the legacy that has been left behind in his name.
Anthony Nolan have given Evie her life back. They found Evie her donor match.
Anthony Nolan is the most incredible charity there is. They are so proactive in what they do. They're so supportive in the people, the donors, the patients, the families.
For me, when I think of stem cells, I think of hope, knowing that one day we may be able to help many patients through what is probably the most toughest time of their lives. It really spurs you on and inspires you to keep going.
So hopefully that gave a bit of an insight into the charity and what we do. But yeah, we're much more than just a donor registry, and that's often a myth that we have to bust as such. It's certainly where our heritage is and where we started as a charity, but we do an awful lot more. So I've just wanted to touch on a couple of myths for you, for anyone that does know the charity. So as a register, we have nearly 900,000 members on the register, as it says there. Anthony Nolan actually runs all of the UK registries. There's 4 UK registers: Anthony Nolan, DKMS, NHS Blood and Transplant, and also the Welsh registry. So together, those registries have nearly 2 million people on them that have registered to become a donor, which is fantastic. And we don't just use the donors for donations. We often use stem cells for conducting research as well. And the charity advocates and also provide lots of support for patients, which I'm going to talk about a little bit further down the presentation. That video suggests that we are a children's charity, perhaps because of the 2 people that were featured in it, but we are not. Stem cell transplant is a treatment that can be used across a number of age ranges. Unfortunately, blood cancer and blood disorders affect children and adults of all age. There's no specific demographic, and so our range of support covers all our age ranges. I'm going to talk a little bit about the different types of transplant later on, but the process of having a transplant from another person is called an allograft transplant. And because of our unrelated donor matching, some people think that we only work with allograft patients, but we don't. We look after patients that are having all types of different transplants where stem cells are involved. And the other myth that we sometimes have to dispel is that we only look after patients in the post-transplant phase. And that's because when our particular arm of Anthony Nolan, the patient services arm, was developed, the focus was very much on the post-transplant phase, but actually we support patients all the way through the process, from decision making about having a transplant right through to years afterwards. So let's get on to the nitty-gritty. What is a stem cell transplant? Effectively, it's a replacement of your blood stem cells with healthy blood stem cells. And this diagram here explains, hopefully in a little bit, an easy diagram of where stem cells come from. So they're largely grown in the bone marrow. The femur, which is your long thigh bone, is one of the biggest places where stem cells are grown, but also in your sternum, the bone in your chest between your ribs, and that's where your blood stem cells, your blood cells, and your plasma, and all the things that circulate around your body to deliver red blood cells, white blood cells, and platelets are made. And as you'll be aware, that if you have a blood disorder or a cancer, when those cells start to grow quicker than the others, they start to crowd out the healthy cells. And so a stem cell transplant can be used to sort of recalibrate that process, basically. So there are different types of the transplant, as I mentioned. There's an autologous stem cell transplant. That's where an individual will have their own stem cells reinfused back to them. Or there's an allogeneic stem cell transplant, and that's where you have another person's stem cells given to you. And that might be an unrelated donor, such as that you'd find on the Anthony Nolan register, or it might be a related donor, such as a brother or sister, or in some cases, in modern day medicine now, we're able to do a parent-child or even a cousin-to-cousin transplant in some cases. So there's lots of options, and that's really important, particularly in the UK, where if you are white Caucasian, you're likely to have you're about 73–74% chance of finding a good match. If you aren't, this drops to about 37%. And because we in the UK don't have particularly large families, the chances of having a sibling match is about 25%. So people really are reliant on the stem cell register for unrelated matches, or for slightly more sophisticated familial matches where it's possible to do. So a stem cell transplant and a bone marrow transplant are two terms that are used interchangeably. And the bone marrow transplant is how we used to do the procedure many moons ago. It is still used occasionally now, but stem cell transplant is the more common procedure. So stem cell transplants are peripheral blood stem cells, which are taken off a donor in a similar way to someone giving blood. There's no operation involved in stem cell donation, and this is the method that would be used for a patient having an autologous transplant. So if you were having your own stem cells returned back to you, they would be taken off from your peripheral blood stem cell, from your peripheral blood. A bone marrow transplant is when the stem cells are taken, well, the cells are taken directly from the bone marrow. So I mentioned that big thigh bone where the bone marrow produces the stem cells. To be able to get to those cells, the donor has to go under a general anaesthetic, and there's a hole drilled into the bone, and the cells are sucked out of the marrow, which you can understand is quite a hefty procedure to undergo. So in the present day, about 90% of the transplants that are done in the UK are done from the peripheral blood stem cells, as opposed to the bone marrow. There is another type of transplant called an umbilical cord transplant, and that's where mothers, having had their babies, will donate their umbilical cords, and they can be the stem cells can be taken off those, frozen, and can be used to transplant into a patient that needs them. But that is a procedure that's done commonly, but not as much as the peripheral blood stem cells transplants. So I've mentioned what an autologous transplant is, but this diagram hopefully helps to understand that process a little bit more in depthly. The autologous transplant is also referred to as high dose therapy, or sometimes stem cell rescue. So these terms are used interchangeably, usually very poorly by healthcare professionals who, roll them off their tongue very easily. And when you are the poor patient trying to understand the ins and outs of all this, it's not very simple. But these are the different terms that you might hear when you hear about the different types of transplant. So before, the first step in the autologous transplant process would be the patient receiving chemotherapy or immunotherapy to achieve a remission from the disease that they're suffering from. And once that remission has been achieved, then an additional course of chemotherapy will be given, and that's called pre-harvesting chemotherapy. And that is to almost put a rubber stamp on and say, we're absolutely sure we've cleared all of those unhealthy blood cells. And when the new cells grow back after the final chemotherapy, they are as healthy as they possibly can be as stem cells. The patient's then given a course of something called GCSF, which is a hormone that encourages the growth of the stem cells. They proliferate and grow much quicker than they would do at their natural rate. And because they're growing so quickly, they spill out into the peripheral blood system and are circulating in your blood. And that's when the stem cells can be taken off in the blood procedure. So you're put onto an apheresis machine, and the stem cells are taken off you, the patient, and then frozen until they're needed. And that can be a number of months, even a couple of years sometimes, before the transplant's actually going to be needed. Sometimes they're just done as an insurance policy in case there is a later relapse or a need for them. Then when the patient is ready to receive the stem cell transplant back, they receive a really, really large dose of toxic chemotherapy. And the idea behind this, this is the thing that's really treating the cancer or the blood disorder. This is a huge dose of chemotherapy that absolutely wipes out the current immune system and any residual unhealthy cells. And as I'm sure many or some of you on the call have experienced different types of treatment, unfortunately, we're not sophisticated enough to only hone in on the cancer cells or the unhealthy cells. There are other cells that suffer as a result. And in this case, it is the individual's immune system. So in actual fact, the stem cell transplant here is used to rescue the cell system. And so after the patients received the large dose of chemotherapy, the new stem cells or the harvested stem cells are defrosted and infused back to them. And these stem cells are really clever, and they find their way back to the bone marrow, back to that large thigh bone. And that's when they start to grow into healthy, normal cells. So in the autologous transplant setting, the stem cells, as I said, are used as a rescue therapy after having very, very high doses of chemotherapy. And if you didn't have that stem cell rescue, your stem cells back, you would be rendered neutropenic without an immune system for a long time, and the risk to an individual being left without an immune system for that long is that obviously infections, etc., can occur. So that's the reason why we use the high dose therapy or the stem cell rescue. In allogeneic transplant or an allograft transplant, another person's stem cells are transplanted into the patient, and as I've already mentioned, that could be a sibling, it could be a child to a parent, or vice versa, or an unrelated donor who's been well matched. And the well matched part is really important. Some people think it's just about being the same blood type, and in fact blood type doesn't have a huge amount to do with transplant matching. The most important part is the immune system. So there's a part of the immune system called the HLA, the human leukocyte antigen, and I might have a very, very close match to another person's HLA, and that would make us a good match as a stem cell donor to recipient. But the process occurs in a very similar way to the autologous transplant. So whether it's siblings, whether it's parent to child, or whether it's an unrelated donor, the donor goes through a fairly similar process, except they don't need to have chemotherapy before harvesting of their cells, because there's no unhealthy cells to get rid of in the donors. They're healthy donors. So they receive the GCSF injections for 4 days before they donate. That does exactly the same thing. It forces all of those stem cells to grow and grow and grow and spill out into the peripheral blood system. They can then go onto the machine, have the stem cells taken off, and then they are sent to the patient that needs them, who will then have received a large amount of chemotherapy and then receive the donor cells. So here's a couple of pictures of what stem cells look like. It can be a slightly underwhelming experience. I think people expect it to be all singing and dancing, but looks just like a bag of blood, really. Sometimes I think autologous transplants are slightly more exciting because you get some dry ice in the process, because they come into the patient's room frozen and are defrosted before they're infused. So the peripheral blood stem cells, as I've talked about, are taken off on a machine called the apheresis machine, and you can see in the left-hand picture there, that's a lovely donor called Sam. A needle, usually it's done through 2 needles in the arms. Sometimes it can be done through a central line that's put into the patient, but usually for an unrelated donor, they would have 1 needle put into the crook of an arm. The blood is taken off, it's spun to get the stem cells off, and then the blood product that isn't needed for the transplant is then infused back into the patient through a needle in the other crook of the arm. And as I said, when they are they're frozen, in some cases if it's an autologous transplant, or they're taken fresh to the patient's bedside. If they stay fresh, we normally want to infuse them within 24 hours of being taken off the individual that they've been donated from. But if they are frozen, then they are defrosted either in a lovely warm bath, as you can see in the right-hand picture here, or there's a little machine that looks a bit like a toaster, and the bags are put into the machine. They're warmed slowly, so they're brought back to sort of room temperature and then infused. So to give you a bit of an understanding of what the process looks like for a patient going through different types of transplant, an autologous transplant usually requires a hospital admission of around 2 to 3 weeks. There are more commonly now opportunities to have a type of care called ambulatory care, where patients can actually stay at home for part or all of the transplant and just come in daily for checkups, and obviously would be admitted if there were any problems that occurred. But that is a relatively new way of transplanting patients, and we've come a long way from, if you perhaps think about transplants, if you've ever seen pictures of people having them in, late 70s, early 80s, they were in big plastic bubbles, no one could touch them. So to have moved from that probably less than 35, 40 years ago to now patients being able to stay at home, sleep in their own beds, etc. It's really fantastic. But there are a number of risks involved. As I've already mentioned, we give whacking doses of chemotherapy, which can cause prolonged neutropenia, where your immune system is not working effectively and you're much more prone to infection. So it's very unlikely that anyone would get through an autologous transplant recovery without some sort of infection occurring. When those stem cells are infused into the body, as I mentioned, they find their way back into the bone marrow, usually in the thigh bone and the sternum. And they'll sit there for maybe a week, just slowly starting to grow and grow and grow. But it's usually 10 days after the infusion before we actually see them being effective and being able to fight infections. And even at 10 days, they're very immature cells, and they haven't got the capabilities to fight infections in the same way that a healthy bone marrow would. And it can take a number of weeks, if not months, for it to really grow into a fully functioning immune system and blood cell system. There's also the risk of toxicity from the high dose chemotherapy. Like I said, it's not a sophisticated treatment in as much as it won't just attack the unhealthy cells, it will attack other cells. Very commonly, the mucous lining of the mouth and the gut is affected by the chemotherapy, and that can cause lots of problems with inflammation of the gut lining, diarrhea, lack of appetite, all sorts of problems. So it's not without its risks, and patients often require to be fed by a nasogastric tube for a couple of weeks if they've got very bad inflammation of their gut lining, etc. And so there has to be a relative fitness in the patients that we're putting through this, because it can be grueling in some cases. As I said, it takes a little while for the stem cells to really grow into a healthy immune system and a healthy blood system again. And so there can be a number of weeks, if not months, after transplant when transfusions are still required by patients. So that would be red blood cells and platelets, and quite regular reviews, certainly coming into hospital after admission at least once a week, sometimes twice a week. And in a case of an autologous transplant that has gone textbook, we'd expect the patient to be at least 6 months post-transplant before they felt sort of back to pre-transplant fitness and capabilities. The allogeneic transplant is a little bit tougher. There are different types of allogeneic transplant. We have a reduced intensity, and then we have a full intensity transplant. And those two terms talk about the toxicity of the chemotherapy that's given, really. But the average stay for a patient having an allogeneic transplant from someone else would be approximately 4 weeks, possibly longer, in hospital. Again, this can be done with some ambulatory care, but it's almost certain the patient will be hospitalized for a good period of that 4 weeks. Again, similar risks to the autologous transplant: infection from prolonged neutropenia and toxicity from the high dose chemotherapy. There's other risks also involved with this, in as much as a patient, as the recipient of the stem cells, there's an immunosuppression tablet that needs to be taken before starting the transplant, and then for a number of months afterwards, because there is a risk that your new immune system that's been transplanted from your donor recognizes your body as a foreign body. So in a solid transplant setting, for example, a kidney transplant, if someone was to have a kidney from another person, the risk in that scenario is that the patient rejects the kidney. In a stem cell transplant, the risk is the other way around, that the new immune system rejects the patient. And that can cause lots of problems with graft versus host disease, where rashes and different systems in the body can be have lots of problems occurring with them. Because it's a slightly more intensive treatment and transplant, it can usually take up to a good year post-transplant to fully recover, and there is often a prolonged period of hospitalisation or returning to hospital for blood products after transplant. So Alison asked me to talk about kind of the use of transplant in the WM setting, and what we do know is often WM is diagnosed in perhaps slightly older patients, and so there has to be a real balance of risk of putting a patient through these types of treatments when there are other far less intensive and risky treatments available. So it's a real balance, and every patient will be assessed and looked at depending on their own risk factors and things going on with them. But more commonly, and I'll go to a slide in a minute, the autologous transplant would be used in the WM setting. Just thinking about long-term recovery after transplant, both transplants, be it autologous or allogeneic, wipe out your immune system, and therefore revaccination of all childhood vaccinations is required after transplant. And that would be the same with things like COVID vaccinations. So patients that are having a transplant today, for example, will have had all their COVID vaccinations before, and they'll have to restart that whole process again afterwards because they won't have any immunity to COVID or to mumps or rubella or any of the other things that we would be vaccinated for. There's a fatigue is as commonly discussed by patients as being quite difficult to cope with after transplant, and then there's other things. I mean, mental health comes into that to some degree, but body image, you know, people can lose a lot of weight, obviously lose hair. If there has been some graft versus host disease or other problems, there can be rashes and various other things that patients have to cope with after transplant. And then there's other things to think about, that being exposed to very high doses of toxic chemotherapy means that there is a higher risk of a second cancer occurring later in life. And so we've got to be really careful that patients are well screened after their transplant to make sure that any early warnings of other cancers are being picked up. And of course, fertility, high doses of chemotherapy will impact on people's fertility. And often in the moment of, I need to have this transplant so that I can continue to live because it's my only option. But later down the line, issues around fertility and also mental health and just coming to terms with what people have gone through can be quite difficult. And there's a few quotes there from different people that have had transplants about what they found difficult after their transplants. So just to give you a few stats about transplant in WM. Hopefully I've got these correct. WM is not my mastermind subject, but I understand it's in the region of sort of 350 to 400 people are diagnosed annually. And because it's very closely aligned to the sort of non-Hodgkin's lymphoma diagnosis, that works out to be 2 to 3% of the total non-Hodgkin's lymphoma annual diagnosis. And as I'm sure many of you on the call will know, at early diagnosis, there can sometimes be no symptoms, and initially there's sometimes no need for treatment. If there is a need for treatment, it's unusual that stem cell transplant would be offered as a first-line treatment. There's usually other treatment that would be offered in the first instance. If there was a relapse after first-line treatment, then autologous transplant may be a consideration. If a patient is particularly young and fit, and the transplant team think it's appropriate, they might be offered an allo transplant, but it is much more common for an autologous transplant to be used in this setting. And to just give you a bit of an idea, in total there were 3,500 transplants done in 2021 in the UK, and of those about 18% were for non-Hodgkin's lymphoma disorders. So that gives you an idea. If you think then that WM makes up 2 to 3% of that population, there's not many patients that go forward for a stem cell transplant for this this disease. So that's kind of an overview of what transplant is and why it might be used. I just wanted to maybe just cover a few of the support offers that we have at Anthony Nolan, so that you as a community know what else is out there should you want to have or get any further information going forward. So as I mentioned, our range covers the whole process, be it from the outset of thinking about transplant right through to managing in life after transplant. The next 7 steps that you can see on the screen there is sometimes referred to as the Bible of post-transplant information. It covers nearly everything that's in the smaller booklets in one big one. But there's lots there to help even family members. Donating stem cells, etc. Is a really popular information resource that we have. There are lots of charities out there, and there are lots of pieces of information, Macmillan Cancer Research, and then various other charities. But what I'd say about our information is it's clearly very specific to stem cell or bone marrow transplant. We hope that it's complementary to the information that's given out by transplant teams, and we hope that it can be used to help clarify what may have been heard in consultations, etc. Another resource that we have is the transplant tracker. So anyone that's having a transplant may wish to use this, and it's an app that's on the phone. It helps you track goals through the transplant. So thinking about mood or exercise levels, what you're eating, all those sorts of things. It's also brilliant for putting in pop-up reminders about different medications or appointments, etc. So that can be found on the App Store of any Apple or Android phone. And then Anthony Nolan does some specific work around support of patients, as I said earlier, that have a stem cell transplant, don't fall into perhaps a cancer category, and they don't have access to grants that an oncology hematology patient might. So we're really proud to be able to offer a small grant, but something that people can access to help with anything to do with their transplant care, really. We often have people asking for the grant to help cover travel, because stem cell transplants are usually carried out in transplant centres. So lots of patients have to travel from their referring hospital to usually a big city hospital to have their transplant. I've talked about weight loss, etc., and infections. So people often need to replace, fridges or microwaves or buy new clothes as a result of their transplant. Application for our grants is done through the specialist nurse or key worker. Patients can't apply for them standalone. They have to have a healthcare professional support their application, but all the information is on the website if you were interested. And to give you an idea, we awarded 298 grants last year. And on the website, we've got some blogs and various other bits and pieces that you might find useful to hear about patients' perspectives. But this one is particularly around the cost of stem cell transplant from a financial perspective, just trying to help remove some of the stigma of asking for help if it's needed. We also offer an emotional support line. We have a helpline where patients or family members or anyone affected by transplant can ring up for help and advice from a sort of a clinical process pathway perspective, but we also offer this emotional support. We are very aware that it is it's not a treatment you undertake lightly, and there's a lot of isolation and heightened emotions involved with it. So having the opportunity to speak to someone that understands the process, we think is really important. And not every transplant centre or every patient gets access to a psychologist. So this is a brilliant service that we're able to offer, not just patients, but anyone surrounding the patient that might be affected. So it could be a husband, wife, you know, a parent or close friend that might want some emotional support. We have they can access this service. And here's just a few quotes from people that have used the test service. I think last year, I can't see the stat on my screen, but it's 105 people, I think, were referred, last financial year. And so it's really nice to be able to offer that opportunity to people to speak to someone, because sometimes you might not be able to speak to your family in an open and frank way. And we often hear from patients saying they didn't feel they could speak to their healthcare teams because they felt they should be grateful for having an opportunity to have a transplant, and didn't necessarily want to, felt guilty about complaining or feeling awful. So this is a nice outlet for them to be able to speak to someone. And then a couple of nice things that we do as a charity, which really looks to celebrating life after transplant. The British Transplant Games is an absolutely wonderful event that's held every year. It's for the patients who have received any type of transplant, be it solid organ or stem cell, and also donors. And they come together in a competition to do all sorts of different sports and activities. And this year we're taking a team, I think, of over 40 people to Coventry in July. So it's a really nice way to bring the community together and celebrate people being well again after transplant. Similarly, for our paediatric patients, we have the family camp where we take away young stem cell transplant patients and their families for a weekend. And that's a really lovely way to allow children that have been in hospital and isolated from friends and peers for a long time the opportunity to feel like they're returning to some sort of normality. And then we've got some kind of online community possibilities. Our Patient and Families Forum is a really nice way for patients and families to reach out to each other and ask for advice or experience from other people that have experienced transplant. It's a really great way to get an insight from people that have been through it. And so that's available on our website should you want to look at it. And then just a couple of other things that we do. We fund specialist nurses and psychologists around the UK in transplant centres. And this map just shows you all the different roles that we've funded in the last 10 years as a patient services team. As I mentioned earlier, the post-transplant care 10 years ago was an area that we really wanted to focus on to make sure that patients, after they'd had that acute admission and the transplant in hospital, supported in the recovery afterwards, because as I mentioned, it can take months, if not a year plus, to get patients back to feeling like they might have done before transplant. And then just finally to talk about story gathering, we started at the beginning with Anthony and Shirley's story in the 1970s, and since then we've used storytelling really to continue the charity's work, be it through patient appeals and trying to get people onto the register, in our fundraising, or just to make people aware really of stem cell transplant and its possibilities and its in treating blood cancers and blood disorders. And one of my favourite things about working for the charity is the opportunity to see unrelated donors and patients come together and share moments. You know, these are strangers that have donated stem cells to patients, and when they get to meet each other, it's a really lovely moment. And you may have well seen things like that happen on Surprise Surprise and This Morning and other things like that. So yeah, just to come full circle to, you know, the way we're able to do what we do and fund those nurses and all the information and the services is through the telling of people's stories, really, and the support we get through our patients willing to do that for us. So thank you very much. I've talked non-stop for 45 minutes. So it's been lovely to be able to share all that information with you, and I'm really happy to take any questions if there are any.
Thank you so much, Rachel. That was really, really interesting. So I really appreciate that.
No problem.
And it's just really nice to know that there's so much information out there for people to go and access. And, you know, there's a charity like yourselves who can provide these answers, because, you know, something like stem cell transplant is quite a big topic. So to be able to have a charity there with that much information is absolutely brilliant. There's a couple of questions on the chat that I'll go through, and then if anybody's got any other questions, then please do just put your virtual hands up and we will come round to you. So there was a question here from Evelyn that says, might some of the infused stem cells mutate at some point in the future in an autologous transplant, as it was your own cells that mutated to cause a disease in the first place?
Yeah, it's a good question. It depends on the disease. So if we are using autologous transplant, for example, in multiple myeloma, myeloma is this is a treatment option for myeloma, but it's not a curative treatment option for myeloma. We know that those cells will mutate, and we know that the myeloma won't be completely eradicated through autologous transplant. But in other diseases, particularly in the lymphoma setting, it's much more likely that that won't happen. It's not impossible, but it's used as a curative treatment with the aim that the lymphoma or associated disorders would be completely eradicated.
Amazing, thank you. There's a question here from Steve as well that says, how long can your own stem cells be kept?
Yeah, I mean, they can be frozen for a while. I mean, they can be frozen for a long time, but I would suggest that usually it's a couple of years, 2-3 years, that they may be put on ice, so to speak, as a potential treatment option should there be a further relapse down the line, etc. There'll probably come a point where if you haven't relapsed after a number of years, then they wouldn't potentially use the stem cells if they were harvested a long time ago.
With you. And then there's a question here from Catherine. Is there an age limit for getting a stem cell transplant?
Well, this is interesting. There's a long running joke in the haematology community that as the consultants get older, the age limit for transplant gets higher. So when I came into stem cell transplanting 20 years ago, I would say that if you were in your early 60s, you're doing well to get a transplant. I've looked after patients well into their 70s now that have had stem cell transplants if they're fit and there are no other comorbidities that preclude them from going into transplant. That's more likely to be an autologous transplant than an allogeneic, but I have seen patients in their early 70s being offered unrelated transplants, because we have moved treatments on so far now that we can do reduced intensity, lower toxicity treatments for patients.
Amazing, thank you. So there's a question here that says, is T-cell therapy different to stem cell transplant?
So I think maybe we're talking about CAR T therapy here, which is quite a new therapy that's been kind of in research processes for a number of years, but it was commissioned, I can't remember exactly how many years, but about 5-6 years ago now. And CAR T is a similar process to that of an autologous transplant, in as much as the stem cells are taken off the individual They're then taken to a lab and they are engineered with basically a bit like an immunotherapy. They're given a target on their cell surface, so that when they're reinfused back into the patient, they can target the specific cancer or disorder that they're there to fight. So it's a similar process, but it's a different sort of scientific technology that's going on in the patient's system, because it's a targeted therapy as opposed to a rescue therapy as it is in the autologous setting.
Perfect, thank you. Nicola here has asked, how many stem cell transplants can a person have?
Yeah, so in the UK, the current commissioning guidelines say that someone can have 2 transplants. I have witnessed myself someone have, say, 2 autologous transplants and then an allogeneic transplant. That's quite an unusual thing to have. Going back to the CAR T, the treatments that I just talked about, it's not unusual that someone might have an autologous transplant, an allogeneic transplant, and then perhaps a CAR T treatment afterwards. But the general commissioning for the UK is 2 transplants.
And I assume that a second transplant would only be considered, again, with those sort of strict caveats of the patient's clinical picture, any comorbidities.
Absolutely.
You know, I suppose it's got to be really quite strict.
I mean, every time you're having these high doses of toxic chemotherapy, you're exposing the body to a huge challenge in recovery. So it's not undertaken lightly by any means if a second transplant is offered.
And so Catherine here has said, if other treatments haven't given 100% remission for WM, would that mean stem cell couldn't be considered?
No, I mean, getting to a complete remission is the ideal. It might be getting to a partial remission that's very small amount of WM present. Every patient's different. It's not impossible, but it's a risk balance, because it's, as I've talked about, it's quite a grueling process to go through. And if it's not going to afford an improved outcome afterwards, the clinicians will really think about whether or not it's the right thing to do to put someone through it.
And there's a question here from Ian, and I think this is a bit of a tricky one to answer, because again, every patient with a transplant is different, and patients are different in themselves. So he's asked, what has happened to WMers, so patients with WM who've had a transplant, if you know any of your experience, or if you know they've reacted differently in any way?
No, I don't think there's any particular differences in the patient cohort for how they would react to a transplant necessarily. As I said earlier, WM does tend to affect people maybe a little bit older, and so that has to be really thought about carefully. Are there any other health issues with that individual? You know, the older you get, the more things you collect, and so that's probably the only real issue is age, and then other health issues that might impact on recovery after transplant.
Okay. And there's a question here from Andre saying, if you took cells from a patient that could not be used, can they then be donated to other patients?
So if you have had a blood disorder and you've had stem cells taken off yourself with the aim that they would be given back to you, they would not be used for another patient. And so that's because when you donate your stem cells to someone, you go through quite a rigorous health questionnaire to make sure that you're as healthy as possible. And so the fact that the individual that's had the stem has been treated for a cancer or a blood disorder would prevent them from being able for those cells to be used for someone else. They might be used for research, and sometimes people are asked to sign could be used for research if they aren't used for a stem cell transplant.
And does it happen quite often that, say, somebody has been deemed fit for a transplant and some cell, they've been matched with somebody, the cells are then prepared? Is it quite, is it a common occurrence that they're not able to be used? Or is it something that, something really has to happen?
So when someone, so if someone needs a transplant and they're having one transplant from another person, an unrelated donor, the transplant team will ask Anthony Nolan to look at the database using that HLA that I mentioned earlier, and the initial matches will come up. And some patients might have 10,000 matches and some patients might have 0. The Anthony Nolan's job then is to sort of select the best, the top 5, top 10 matches, and they'll be taken back to the transplant centre, and the clinicians, the consultants, etc. in the hospital will make a decision over who they would like to use. When we're given that information from the hospital, we'll then go to our donors and say, you've been matched with someone, we now need to do some more robust health checks on you to make sure that you are still able to donate, and also check with them that they're able to. And it's not uncommon that someone isn't able to donate for whatever reason. They could be, about to start a new job or relocating, or it just isn't the right time in their life to do it. So then the next person down on the list would be approached, etc. Yeah, so we've had cases where someone might have had, 2 or 3 different donors approached and not been able to donate and move down the list. And that's why it's really important that we continue to build and diversify the register, so that those patients that might only have 1 or 2 or 0 matches do have the opportunity for another person potentially to donate to them.
Amazing. Catherine has just asked, would you expect your WM consultants to suggest a transplant, or should you ask for it?
It may well be something that's discussed if the consultant feels that it might be an appropriate treatment option. I don't think there's ever any harm in saying, I know that stem cell transplants used in this setting occasionally. Is it something that I might be considered for? Often if a clinician or a team feels that transplant might be utilised down the line in this disorder or any other, they might alter the treatment that they give in the first instance, because you want to try and minimise the toxicity to the patient, so that the transplant has the best chance of working.
Amazing. So there's just one, I think we'll just take this one last question. Oh, unless so Maureen, I'll come to you in a second. I'll just ask this last one off the chat, then we'll go to Maureen, and then I think you've definitely gave us enough of your time. So Evelyn has asked, do you have to go to a specialist centre to have the transplant?
Yeah, usually. So in the UK, there are about 25 centres where you can have an unrelated or a transplant from another person, an allogeneic transplant. They are specialist centres dotted around the UK. Those centres will also be able to do the autologous transplants, and then there are a number of sort of smaller district general hospitals that can also do autologous transplants. They usually don't do loads and loads of them. It will be 5 to 10 a year, as opposed to those bigger centres that will be doing upwards of 100. Which doesn't make it a better or worse place to go, but I guess it's individual choice and where you feel most comfortable.
Amazing, thank you. Maureen, if you wouldn't mind just unmuting yourself.
Okay. Hi. Hello. Just to say that I had a stem cell transplant last October. My WM, which was diagnosed in the beginning of 2020, and after treatment, it transformed into diffuse large B-cell lymphoma. And then I had a course of R-CHOP, and it was suggested that perhaps because the mutant genes I had a stem cell transplant would be suitable. So that's what I did last October. And
how are you doing, Maureen?
yeah, pretty good actually. I mean, it's been a long haul.
Yeah.
It is a very difficult treatment, and I'm 74 anyway, so I'm not a spring chicken. But yes, I'm getting there now.
Good.
Yeah.
You look really good.
It's the guts more than anything else, but apart from that, yeah.
So what I said about, you know, a real balance of, you know, risk versus benefit, you can understand that really, can't you, having been
absolutely. Yeah, absolutely. Yeah, it was not a difficult decision to make really at the time.
No,
it seemed the only way forward. Yeah.
And
but just to say that, you know, I'm perhaps in a success story here.
Fantastic.
Yeah,
that's the perfect way to end.
Maureen, thank you so much for sharing that. That was really lovely.
You're very welcome.
But yeah, Rachel, just again, thank you so much for coming along and doing this session this evening, because I think it's been recorded and it will go on our website for people to dip in and refer back to. And I just think it's a really brilliant subject for people to learn a bit more on. So thank you so much for giving up your time. We really appreciate it.
Well, thank you very much. And please go to the website, have a look around, and there's loads of information there. So and we've got the forum and the email and the helpline. So if anyone has any further questions, please ring our helpline. You can speak to me or one of the team if you've got any further questions.
Amazing. Thank you so much. Right, guys, thank you all so much for coming, and have a lovely evening. Thank you, Rachel. Bye.